Good afternoon and good morning to those of you on the West Coast. Welcome and thank you for participating in today's ISMP webinar titled Introducing ISMP's New Targeted Best Practices for 2018 through 19. My name is Alan Veda. I'm a pharmacist and the Executive Vice President here at the Institute for Safe Medication Practices, and I will serve as the moderator for today's program. Brief background: ISMP first introduced the targeted medication safety practices for hospitals back in 2014. They're promoted as two-year goals, and we hope that all hospitals are able to achieve them. They're based on medication errors that have continued to cause harm, some leading to fatal events in patients that continue to recur despite repeated warnings from ISMP and even other national organizations. We have a national advisory panel that helps us identify and establish these best practices every 2 years, and today we'll address our third iteration of the best practices for 2018 through 19. Our speaker today is Dr. Daryl Rich, Medication Safety Analyst at ISMP, who has helped lead this effort since its inception back in 2014. Daryl's background includes serving as a surveyor for the Joint Commission in the hospital, home care, and ambulatory accreditation programs. In addition, he worked for the Standards Interpretation Group, serving as an internal resource for the Joint Commission related to pharmacy and medication management. Before starting at the Joint Commission in 1993, Dr. Rich was National Director of Pharmacy Services for Critical Care America, a national home infusion company, and he had previously served as Director of Pharmacy Services at Boston University Medical Center and Clinical Assistant Professor of Pharmacy at Northeastern University. Dr. Rich is an active member and fellow in the American Society of Health System Pharmacists and a past president of the New England Council of Health System Pharmacists. He has received numerous awards, given over 600 invited presentations, and has authored numerous publications and referee journals, including 8 books and 4 video series. Daryl received his Bachelor of Science degree from the University of California at Davis, his Doctor of Pharmacy degree from the University of California at San Francisco, and a Master's in Business Administration and Healthcare Management from Bryant University in Rhode Island. Dr. Rich will review the implementation of the 2016-17 best practices and present the new best practices that were added for 2018 through 19, along with talking about some revisions to our best practices. Before I turn the program over to Daryl, I would like to make a few announcements about some upcoming ISMP programs. On February 21st and 22nd, ISMP will be conducting a medication-focused Just Culture certification course with Outcome Ingenuity in Scottsdale, Arizona. And on April 5th and 6th, we'll be holding a medication safety intensive program in Philadelphia. More about either of these programs is available at our website at www.ismp.org. Please note that all your phone lines are muted to cut down on background noise. If you're logged in on your computer, you could submit questions on the portal under the questions pod. If you're logged in using a mobile app, you can ask a question by clicking the question mark located at the top of your screen. Feel free to submit questions throughout the presentation. We will not be taking any questions over the phone today. If you'd like a copy of the speaker's presentation, you can access it under the Handout tab on the GoToWebinar portal. With that, I'll now turn it over to Dr. Rich.
Well, good morning or afternoon, everyone. First of all, just to let you know, I do have no conflicts of interest with regard to this presentation. And these are the 3 learning objectives for the presentation. But I just want to tell you what I'm going to do is talk about some of the how well the 2016-17 targeted medication safety best practices were implemented based on a 2017 survey we did. Talk about, as part of that survey, we actually asked a number of people what were some of the barriers if they could not implement them fully. And so we'll talk about some of those and some of the strategies around that. And then we'll talk about the 3 new best practices and what those new best practices, what kind of errors they're designed to prevent, or at least to minimize. So back in July of 2017, we conducted a survey. We did ask people their level of implementation, and we asked them what were some of the barriers that they had. So we'll talk about that, as well as what could be done to overcome those. And as I said, we'll talk about the new ones as well. Now, there were some barriers that actually were consistent with almost every goal that people were having trouble implementing. And those were basically things like lack of buy-in from others, be it physicians, nurses, the leadership of the hospital, even other pharmacists in their own department. And we consistently got a message that a lot of people just were not convinced that these were important or that they were a priority. There also was just a unwillingness or an inability for people to change the culture and practice within their organization. They felt it was just too much effort and something that they could not do. There also was, even among the respondents of the survey, a lack of perceived risk for some of these. And we'll talk about that, but there was just some that felt that, well, we just don't do this very often, so it's not an issue at our hospital. Also, in some of them, we saw EHR limitations as a concern. Either it was through a lack of IT support, that they had a shared system with other hospitals, so they were sort of powerless to make changes in the EHR, and some actually felt that their EHR just wasn't capable of doing the changes that were necessary. There were some concerns about workload and inadequate staffing, as well as the cost of some of these particular best practices. There was a talk about not having enough space for some of them. And one of the ones I thought was kind of interesting is some people, they knew they couldn't do everything perfectly like in the goal, so they didn't want to try it all. So there was like this need for perfection in order to implement it. There was an inability to understand whether it was implemented or not. Sometimes they would implement a policy, but they had no idea whether the policy was being followed, or they felt that some people were following it and some people were not. And then finally, there was a lack of understanding of the best practice itself, and not understanding that many of the best practices that require an EHR or an automated solution, there were alternatives to that electronic or automated solution, and the people really didn't understand that they had those options available to them. So those were the common barriers. I'll talk about ones that are specific to each one as we go through them. But let's look at the first best practice from before, and this was dispensing vincristine and other vinca alkaloids in a mini bag. As you can see from the green bar, that's full implementation, that it has consistently risen over the years. And while we did have no compliance, which is the orange bar, you can see that that's also decreased significantly over the years. The partial seems to go up and then down as the full implementation goes up. So actually, we're up at around 86% implementation for this best practice, which we feel is very good. Some of the barriers to this, again, the ones in black are the ones that we already talked about, but there was some concern with this particular barrier that there was an inability to check for extravasation. Even though on our FAQs on our website, we have posted numerous articles that show that extravasation is not a concern with the use of mini bags with these particular products. But there was concern by some people that because the mini bag took a little longer to infuse than push, that the nurse just needed more time to check for that, and they didn't have that time available. With our second best practice, this had to do with oral methotrexate. First, we talked about a weekly regimen default, and we're up at almost 80% with that one. And again, it's grown tremendously, where you could see non-compliance has dropped tremendously. With this one, we had some concerns. Again, EHR limitations was the big one regarding this, but there were some unique things here where they talked about too much variability in dosing to allow defaults, or they had a system where medication reconciliation imported the orders and they couldn't change them, which I think is a safety concern in and of itself. But there are other things that, again, which we talked about, and this has to do with when we said that there was a lack of perceived risk. Again, the fact that they don't use much oral methotrexate, they felt that they didn't need to worry about it, where actually many organizations need to understand that the least frequently you do something, the more chance of an error getting through is. So that actually would be more of an indication for why you should do it. The second part of that best practice is a hard stop verification, and here you see the implementation is significantly less. It has improved, but not as much as in others. We only at 42% with 30% partial. And again, a lot of this has to do with the EHR limitations. They just cannot do the hard stop. And again, we do want to point out that we do have a non-automated alternative, that if you can't do a hard stop, we have a process where we ask you to clarify, if it's not clear from the orders, who is the, or what the diagnosis is. There are some, we didn't understand this very well, but there were some cultural variations to the use of methotrexate. And they were concerned about the impact on treatment plans of a hard stop. When it was a part of a whole treatment plan, would stop the whole treatment plan. And then there was concern about alert fatigue. This one had, again, more. There was a fact that the indication is not readily available, so that was a concern about the system. But again, a lot of the same issues that we talked about earlier. The one that I thought was kind of interesting was the fear of forcing people to do their jobs, which I thought was an interesting comment. But it gets at the point that some people just are not effective at convincing others, and even when there's authority over other people, it may not be as effective as one thinks. The last component of this particular best practice has to do with patient education, and this is one of our least implemented best practices and continues to be that way. And as you can see, it improved. Initially, there was 78% of people didn't do it. Now 40% do and 24% don't. So it has improved, but it's still not where we would like it to be. Here we had a lot of issues with the feeling that there was a concern that this would delay discharge, and leadership did not want nurses doing that. There was also the concern here that this really is a nursing function, and there was no way to convince them to do it. They didn't have the buy-in, or they weren't sure if they were doing it or not doing it. And then finally, there was some concern that we do education at the start of therapy. We don't need to do it again at discharge. And I think most people in healthcare, particularly nurses, would probably disagree with that thought process as well. You need to remind the patient constantly with education, both throughout their hospital stay and then at discharge. The next best practice has to do with weighing each patient on admission, not using stated, estimated, or historical weights. This is one of the newer revisions for 2016. The other ones were actually implemented in 2014. And again, we're seeing some improved compliance here. Not as robust as we'd like to see. It's only 44% again. And the answers we see are hinders the emergency department flow. There's a culture around this that can't be changed, and it does affect the flow and design of the electronic health record. So this really is something which people feel is not as possible for some of these different reasons. Again, we see some of the same issues of we have a policy, but we're not sure it's followed, and that we have some financial limitations. We don't have the scales to do this properly. The second component of this actually was released in 2014, and this is that you document and measure patient weights in metric units only, and we have seen improved compliance with this over time. As you could see, not as robust as some of the other ones that we've seen in the past, but certainly we're seeing improvement with this as well. And again, some of the same issues here that that there's pushback from physicians and nurses, that there's some limitations to the EHR system, or they just don't have bed scales that can be locked out. And one person was concerned that the EHR can be locked, but not the scales, which they thought posed a safety risk. There was concern about outpatient clinics being a problem, and families still insisting on weighing pediatrics in pound, even though in our revision to this particular best practice, we recommended you still weigh the patient, but then use a conversion chart to tell the patient's family what the weight is in pounds. And again, we got that same statement about fear of enforcement and worker comfort is the priority rather than making sure people do their jobs is something that which could not always be achieved, which again thought was interesting comment. Now, best practice 4, that non-unit dose oral liquids are dispensed by the pharmacy in an oral syringe. We had good compliance to start, but as you can see, it's gotten even better. We're up at about 72% full compliance. There still is some concern about the availability of prepackaged items, the cost of unit dosing, the shorter expiration time. They still want to dispense the bulk product. And so there was that and concern about time and manpower to unit dose things. Even though this has pretty much been a standard of practice with ASHP and others for many years in pharmacy practice. There were a number of other very specific ones related to this. There were some concerns about some advisories that came out, but that really was not about oral syringes, it was about injectables. So I think maybe the responder was confused a little bit. There was some concerns about how USP 800 is going to affect this, the lack of stability information out there. Some people did say there were only a few exceptions, oral mouthwashes and certain compounded drugs, and there was some concern about controlled substances. So these are very specific, unique situations that people said they couldn't do it in, but they were very limited in the number of cases which they couldn't. And as we go through this, we're going to talk a little bit more, but there's almost always going to be exceptions under unique circumstances like drug shortages and things of that nature, where you may not be able to do it for a limited period of time, but yet you still need to try to do it when you can. And I think that's, we know it's not going to be 100% of the time. And I think that's, but the system should be designed to try to achieve 100%. We revised this particular best practice for 2018-19. We wanted to make sure that we included infit syringes in this. So as infit syringes come out, we are going to see that people are going to be using those more than oral syringes. So we wanted to put that in the best practice. We wanted to make people understand that this is not about the syringe. This is more about unit dosing. And so we want to make sure that they understand that it's the bulk oral solutions we don't want stocked in the patient care unit. Also, we did revise that second bullet. We did have some concerns. People didn't understand why we were requiring an auxiliary label when it already said oral use only on the syringe. And again, It had to do with the fact that some oral syringes, it may not be that distinct, and we wanted to make sure that it was. And that we wanted to make sure that the rest of it is kind of wordsmithing. But we wanted to make sure that if you do use the infit syringes, that you do affix or at least highlight on the label, because I know some people adhering a auxiliary label is too time consuming, that it says for oral use only, because the infit syringe says for intraoral use only on it. And we don't want people to think that that's the way you want to be administering this. So you do need something that at least informs the nurse that it is for oral use if you're going to use an infit syringe for that. Also, we did put in the exception, which actually is in our FAQ, which is that if you do have unit dose automated packaging in cups or bottles, then you don't have to do the syringes. But you should make sure that the syringes are available on the units for those patients who can't drink from a cup or a bottle, and that way the nurse is not using a parenteral syringe to try to draw it up and administer it. Best practice 5, as you can see, we've gotten really good compliance with over time, and this is using oral liquid dosing devices in metric units only. There still is some concern about lack of availability, but we are aware of much more in terms of availability of oral syringes that are available in metrics only. Now cups are available, and they're with the black printing rather than the embossed printing, making it more readable. Now, I do understand that there may be some material management resistance, and there's concerns about existing contracts. But this is something that, again, could be worked on more. Best practice 6 was always our best implemented best practice. And as you could see, we did have concern at the beginning with only 28% of people really saying that they weren't doing this. Excuse me. Now it's down to 4%. With 94% of the people actually having implemented this. There is some concern that certain departments say there's no acceptable alternative. We find that that's not true because other hospitals have been able to do it. And the one about still needing in pharmacy for compounding, that was one of the things that we said was not necessary. There should be no reason you need the glacial in the pharmacy. You should be able to use the other acetic acid products out there to compound with. So that's, I'm sure it's based on the fact that they're using an old compounding sheet, and rather than revise it, they just feel they still need it. Best practice 7 was one of the newer ones for 2016, and so we don't have as many years of survey data here. This shows you that it is also rapidly increased over the last few survey cycles, which was basically every 6 months. The issue here is, and what we see with this is the part of this particular best practice, which is the most hardest, or the one we find most implemented the least, is the fact that the pharmacy doesn't segregate it in the pharmacy. And so people do talk about space limitation, the lack of refrigerator space for lidded bins or locked boxes. And there was some concern about the anesthesia automated dispensing cabinet and the OR workstations. They couldn't segregate things. We did clarify that a little bit in the revision to this best practice. We'll talk about that. But there also was concern about lack of support for change in the pharmacy itself. People didn't want to change their compounding practices and where they stored things in the pharmacy. And we felt that that was a concern. Now, for this one that we revised in 2018, we did make sure that you understand that when we said eliminate storage of neuromuscular blockers wherever they're not needed, we meant routinely not needed. And so we wanted to clarify that it's because you may need something once in the blue moon in a particular area doesn't mean that you necessarily have to have it there. But if we wanted to make sure that it limited it more than what we think people were doing. Also, we wanted to make sure that when we were talking about rapid sequence intubation kits, we're talking about patient care areas, not just other areas. And then finally, we did change the wording here a little bit. We wanted to be consistent with our high alert medication self-assessment and some of the wording that's out there. We want to say causes respiratory arrest, patient must be ventilated, and to clearly communicate that the respiratory paralysis will occur and ventilation is required. The fact that it's a paralyzing agent should be pretty obvious, but the other thing too is we want to make sure that the auxiliary labels don't necessarily need to be on the vials, that the vials are clearly labeled that way. So we did cross that out and just talked about the syringes and the IV bags. We also wanted to make sure that we are excluding anesthesia-prepared syringes of neuromuscular blocking agents. We feel that's a situation where this is not necessarily needed. So again, we did make some revisions in this, relatively minor, but to clarify this with some concerns we had over the last couple of years. Best practice 8 deals with administering all high alert drugs by smart pump with dosed air reduction software. And as you could see, when we first did our baseline, only 44% were doing this everywhere with all high alert drugs, and now it's up to 78%. And again, some of the issues here was the cost of smart pumps for those areas that didn't have them, particularly such as the operating room and the ambulatory clinics in the ED. There was some resistance in the OR, but the issue here most people had was using the drug library consistently, getting the nurses to do that. So getting the pumps there was less of an issue, more of an issue getting the nurses to use them properly. Best practice 9. This one, as you could see, was not very well implemented at all to begin with, and but it was sort of a partial, always from the beginning, and then it gradually increased, and now we're doing much better with it. With this particular best practice, we're asking that reversal agents be available in the area, that there be wherever those drugs are stored, and there be directions for their use with a standardized protocol, so they don't have to wait for an order. And what we heard most consistently on this is we're working on it, we're just not there yet. So clearly a lot of people are trying to get there, it's just a matter of time. And so we're much more hopeful about this best practice. Again, people saying, well, they're not doing all the antidotes, just some of them. There's a cost of outdated vials of the antidotes, and the fact that it's a low volume usage, so it's not a priority, and then drug shortages. And again, I think in times of drug shortage, you have to do things differently, but clearly under normal circumstances, that we would hope that would not be a reason not to do it, is because there may be a drug shortage in the future. Best practice 10 is not storing 1 liter bags of sterile water anywhere outside the pharmacy. And again, we see great improvement in this over the course of the surveys. And there's still some respiratory department resistance. There is some concern that they're needed for the NICU isolates or the vapotherm machines. And the OR, again, this is the area we feel that it's probably the least problematic, is in the OR, where the 2 liter bags clearly could be used. But the other issue that we consistently heard is the vent poles don't hold the 2 liter bags. Well, actually, they break with the 1 liter bags. They're not designed to hold a bag. They're designed to hold a circuit. And you can buy a pole to hang a bag next to the vent machine, but apparently people are either not aware of that or they're not buying it, one or the other. The one of concern to us is the feeling that the sterile water bags look different, so it's not an issue. We have had error reports of people with products that are a little different in their labeling, but yet still person sees a 1 liter bag, grabs it, thinks it's D5, and it's not, it's sterile water. And then the last of the best practices for 2016-17 has to do with the essentially the elimination of the pullback method to make sure that you verify the ingredients in amount prior to the addition to the IV bag rather than after. And again, we're not seeing good compliance here, 39%. We are seeing some partial, but again, not full. And here, the issue I think is interesting is the perceived workflow interruption and wait time, the feeling that this somehow makes workflow and workload inefficient. We actually, there was a couple studies at the mid-year this year where they showed that actually workflow improved and workload decreased and the efficiency improved. So this is a misperception of reality and is a problem. I do see many people responded based on the fact that they really can't do this without technology, and they haven't been able to get the technology yet. So we do see that as a common one for this particular issue. Although the recent ASHP study in this area has shown that much more improvement in the implementation of the IV workflow software. So as we talk about some of these barriers, there's a couple things we'd like to talk about. One is there's a need to overcome the unwillingness to change culture and practice. And we realize that changing culture and practice is not simple and it's not quick, but it's something that people need to work on. And I know that as we, Alan mentioned that there's the Just Culture Symposium coming up, but we also feel that there's a need for people who are in positions in pharmacy to implement these, usually a medication safety officer, to get those management skills that deal with how to justify and gain cooperation from people who you have no authority over, or even if you have authority over, how do you gain their cooperation and help justify implementation of these things? We actually are going to be doing a session at the ASHP summer meeting this coming year on this, and hope to do more on that at the mid-year as well. I do think that it's important that people understand that this is a skill that I think people need as we move forward. Don't accept EHR limitations as a vendor issue. We got a lot of comments that our EHR system just doesn't do it. We have whatever system, Epic, Cerner. Well, then we find out there are people who have the same system and they can do it. So we feel that sometimes the IT department is telling pharmacy that without it being necessarily true, just to get them off their back. So what we're telling people is just don't accept that without really researching it and talking to the vendor and others to find out if it's true. Because in most cases, we believe it's not. The other thing is it's a low volume, so it's not an issue or a hospital. And I think I mentioned that to you already. It's much more prone for error if you don't do it routinely. So, and that's why people go to the hospital that does the most of any particular procedure, because they have a lot of practice at it, where another hospital only does it on occasion. The chances of not doing it right are higher. The ensuring compliance, you don't need, the only way you're going to ensure compliance is measure it. And that's a problem. I think a lot of people don't have measurement systems in place for these. So you need to think about that and consider that. That's the only way you're going to ensure compliance, is to find out and measure if it's actually happening. Minimize exceptions, but don't expect perfection, again, in terms of drug shortage and other times. And use creativity to address workflow, space, and resource needs. We've seen that in a lot of hospitals who've done well with this. So one of the things that we're asking hospitals is, in the last, based on this survey, the ones that are still not at a point where we think they're doing well are these specific 6 best practices. So we really are asking hospitals to focus on these more in the coming year. We do repeat all of our best practices as we put them out there, so that people who may not have implemented them, they don't lose sight of them and figure, well, I don't have to worry about it anymore. We do want the ones that are the earliest on, the 2014, were the ones that were the most important, that we got the most error reports and deaths reported. As we move forward over the last 2 years and the next one's coming up, you'll see we're only adding 3 this time because the number of issues is becoming a little bit less, and they're much harder to solve with 1 or 2 best practices as we move forward. So let's talk about the new best practices. The first one, best practice 12, is to eliminate the prescribing of fentanyl patches for acute pain in an opioid-naive patients. This is clearly based on the package insert, and this is clearly one of the cases where most harm has been caused related to fentanyl patches. There are a lot of other issues that you could talk about with fentanyl patches, and there's a lot of issues you could talk about with long-acting opioids, but we really felt that we really wanted to focus just on the fentanyl patches in this particular issue. Now, to do this, you have to have a process in place to routinely document whether the patient, what their opioid status is, whether they're naive or tolerant. And actually, we've included the definition of opioid tolerance in the FDA definition in the best practice so that you can actually see that. You also have to document the type of pain, whether it's acute or chronic. And that needs to be either in the prescriber's orders or in the health record somewhere so that people know whether or not the patch is appropriate or not based on these 2 factors. The second thing is you need a process to prevent or verify orders for fentanyl patches in these patients, which means someone's got to be able to, when an order comes through, to make sure that it is for a patient who's opioid naive or acute, has chronic pain. Examples: hard stops, alerts, automatic interchange, pharmacy intervention with prescribers, any of those things. We're trying not to be super prescriptive, but we want to make sure that you prevent orders in these patients who are opioid naive or have acute pain. They shouldn't be getting a fentanyl patch. And there needs to be discussion with the prescriber. There needs to be some kind of alert or stop process implemented. And then the last one is fentanyl patches should not be in automated dispensing cabinets or in floor stock areas where acute pain is primarily treated, such as in the emergency department, operating room, post-anesthesia care unit, and procedural areas. These typically are all areas where patients come in with acute pain, and to prevent their use in that, we recommend that you just eliminate the storage of patches in those areas and require that they be dispensed by the pharmacy if necessary. So what I'd like to do is ask you a question, and we do have a poll, and you will be able to answer the poll, but we would like to know, where do you stand with this? Kind of like a baseline. How have you done this? We know this may be new to you, but even before we started the best practice, where were you with this? So why don't you answer the following poll, and we'll see how people do. We'll give it just a few more minutes. We're up to about 50% of the people voted. I wish I had some music to go along with this. Maybe I should get my iTunes out. You probably wouldn't like my choice of music, though. We'll give it a full minute here, and then we'll close it out. Well, it doesn't seem to be going anymore, so we'll just close it. All right. And so this is the results we got. The vast majority of people say they partially implement it in either some aspects or in some locations. Full implementation is around 18% and 12%. This is about what we expect with a new best practice So really, I think that that's very good with this. Okay, so let's move on to the next best practice. This one has engendered probably the most comments of all the 3 new ones that we've put out. But eliminate injectable promethazine from the hospital. And we're saying it shouldn't be there at all. And so we suggest that you remove it from all areas of the hospital, including the pharmacy. You classify it as a non-stocked, non-formulary drug. You implement medical staff approved automatic therapeutic substitution policies to convert all injectable promethazine orders to another antiemetic. That you remove it from all computerized order screens and order sets and protocols. And basically that's it. But I do, we're going to have another polling question on this, but I just want to tell you that we're talking about injectable. And it doesn't matter whether it's in a bag or a syringe, IV or IM. And we have gotten lots of comments on this with regard to the fact that some people feel that there just isn't other alternatives out there, but there are about 4 or 5 other antiemetics that could be used. A lot of people aren't familiar with all of them. And also that there are a number of organizations that have successfully done this. And in fact, the Medication Safety Officers Society is having a free webinar for its members next month. And one of the people there is talking about a multi-hospital system where they successfully eliminated promethazine from all the hospitals and all areas of the hospitals at their institution. So it is possible to do. It's just that some people just have not really looked into this. So with this in mind, I would like to actually start the next polling question, which is, how are you doing with getting promethazine out of your hospital? Have you done that? Have you eliminated it from all areas or some areas or what? And just to to clarify, the reason we are asking to eliminate it is because given IV push, it causes extreme necrosis. It results in amputation of digits and arms and other things. It's just really serious. And unfortunately, people say, well, why is it serious IM? And you can give it IM. The problem is people accidentally give it IV by mistake, push. They cause this necrosis, and it really is difficult for all the patients who experience this. Extremely harmful and painful to the patients involved. Okay, so now let's see how did we do with that. 55% haven't implemented it. 11% fully implemented it, and another 17% partial. So this one clearly is one that a lot of people are having trouble with, and hopefully we'll have more information and provide information about how people can go about implementing this in an organization based on these other organizations that have done so, and we hope to do that in the coming year. Now let's take a look at the next best practice. Oops, excuse me, went too fast. And this one is kind of a motherhood and apple pie one, but it basically says that you need to seek out and use information about medication safety risks and errors that have occurred in other organizations outside of your facility and take actions to prevent similar errors within your organization. So we're saying that you find out about what's happening other places, and you actually try to take action within your organization to prevent it proactively. One of the things that has created quite a concern for ISMP is the fact that most of the regulatory bodies, including Joint Commission, look at gathering error data and then preventing it. It's a retrospective process. You're looking at what's happened in your own organization, and then you try to prevent it in the future. We're saying you need to look at what other things that happen at other people's places and then proactively fix it so it doesn't happen in your place. Now, with that in mind, we recommend that you appoint a single healthcare professional for responsibility and oversight of gathering this data and sharing it within your organization. And we say it should be a medication safety officer preferably, but if not, you just need an individual designated, because if you don't have one person in charge, then it never gets done. You want to identify reputable resources to learn about risks and errors that have occurred externally to improve. You want to establish a process for monthly review of those errors reported by other organizations and talk about them with either a new or an existing interdisciplinary team or committee responsible for medication. And so you should be able to looking at a review of your current medication systems and other data such as internal medication to determine what risk points and what would allow that error to occur within your organization. And discuss it at your committee and see if there indeed is something you could do that would prevent it in the future. You need to determine the appropriate actions to be taken, document the decisions reached, and gain approval for the required resources that may be necessary, and then share these stories of risk with all staff, along with any changes that will be made in the hospital to minimize their occurrence and begin their implementation. And then finally, once implemented, you need to go back and check to make sure that they actually are implemented. And share those results and the lessons learned so that people will see that there's improvement and be done. Some people say this is essentially saying it could be done simply by taking the quarterly action agenda from the ISMP newsletter and bringing it to a medication safety committee, discussing it, filling out the form, and then implementing those processes to prevent those errors at your own organization. So with that in mind, I'm going to do our last polling question, which is, where are you in relationship to a proactive assessment of this particular, within your organization, of errors that have occurred at other organizations? How are you doing with this? So I'll take about a minute here to see you answer the question. Okay. So what we see is the vast majority of people, again, partially implemented, full implementation at about 20%, and there's still 10% that have really not done this yet. So we really are, this is another one that I guess we would say is pretty typical of what we've seen when we implement a new best practice as a baseline. So I do think that this gives you a pretty good idea of where people stand, and the fact that I think with all of these, we've seen at least some percentage of people that have fully implemented it suggests that it is doable, it is workable, and hopefully going forward, we'll be able to do something with that. So, in summary, we want you to focus on assessing and implementing the 6 old best practices where implementation levels were low, and we identify those for you. We want you to improve your skills to implement changes in your hospital by working with others, convincing them. There's all sorts of techniques which have been already identified, and it's usually in the management literature, the kind of stuff that clinicians don't get access to, that talk about that, about getting someone to, in that particular discipline, like a physician, to support your position, to look at what kind of things actually they're interested in. What are the things that drive them to make change, and how you phrase the discussion and the discussion points to appease to that, to get them to change their mind. So again, we think that those skills are necessary and something that need to be worked on by everybody. And then lastly, we want you to assess and implement the 3 new best practices related to the fentanyl patches, injectable promethazine, and proactive risk assessment. And particularly for those organizations that have already done all the ones that are, all the previous ones, 11 that we have put out there. So with that in mind, at this point, I think we're done a little bit early, but I would like to open it up for questions.
All right, thank you, Daryl. As I said previously, you could submit your question on the computer. Just enter it under the tab, or if you're on a mobile app, you could ask a question, submit it by clicking on the question mark. And we do have quite a few questions here. Daryl, I'll try to go through some of them now with you. I'll just begin with the surveys that we did. Did we actually break them down by discipline?
Yes, we did break them down by discipline. Most of the surveys were done through our newsletter with and we did get demographics back, the size of the hospital, who the person was who was answering the question, and so forth. I don't have that information readily available, but that information can, I can answer that maybe offline and post that on our website. We did do our last baseline survey that we did back in February of 2016 was done through a webinar like the polling we did here. That we do not have information, that kind of information on. But certainly the one we did in July, we do have that information.
All right, thanks. Another question is on for best practice number 7. When you were mentioning the auxiliary labels, this participant is asking, does that mean that we no longer recommend auxiliary labels on manufacturers' products?
I think we're saying that if it's very clear on the manufacturer's product that it is a paralytic agent and it can cause respiratory arrest and that patient needs to be ventilated, then I don't think we don't believe you need to put another label on it. In fact, if you put a label on it that may cover up other important information, that could actually make it worse. So we're saying it's really not necessary. But you have to look at the product on a kind of case-by-case basis and determine, is it really there or not? And sometimes it's only on the cap, and the cap could be gone. So that's something that's going to be an individual organization decision based on the products they use.
Okay. And then we just had I'll give a couple comments from one participant too, regarding the 1-liter bags or the 2-liter bags of sterile water. Just making a comment that hospitals should just stick with the 2-liter bags, even in pharmacy, so that you don't even have them available in there.
Right. And that indeed may be possible. I think the only reason people were talking about the need for the 1-liter bag was because of some of the compounding equipment they had in the IV room and so forth. But certainly if they could use the 2-liter bag and they could get rid of the 1-liter bags altogether, that's even better.
We also have a few comments here on the promethazine. One was, you had mentioned that there was going to be some information at some hospitals that have successfully eliminated this. Do you know if any of those are pediatric hospitals?
I do know the One Health system does have pediatric hospitals within them, within that system, and I'm not sure about others at this point. I was only familiar with the one organization who is Ohio Health, and I'm not sure exactly how some of the others have done with that in terms of pediatric hospitals. Our plan is, and what we're trying to do is find out those organizations that have done it and see if they're willing to share their information. And we're planning on posting that on the FAQ on our website to help people.
Good, good. And I think anyone on today's call, if you have successfully done this, please send us a note so that we're aware of that too, and probably could get the opportunity to engage you in helping us achieve this best practice.
Right.
Another one, of course, on the promethazine too, is that it sounds like this hospital's getting some pushback too, that one of the physicians wants to know the incidence or rate of harm with promethazine per 1,000 patient days. And just a little bit more, you did mention at the end with promethazine, but what is some of the other reasoning for eliminating this product completely?
And I think originally when ISMP has been talking about this issue for years, at least 10 or 15 years ago, this was brought up. We have some very graphic pictures in our newsletter of severe necrosis resulting from this. And it has to do with IV push administration into extremities and other areas. And I think that, first of all, in terms of 1,000 days, I mean, it isn't an error that occurs routinely. It's given wrong once, and then the error and the severe harm happens immediately. It's kind of like the intrathecal administration of vincristine. You do it once, and it's the damage is done. As I mentioned, I think some of the issues have to do with the fact that originally we did not feel there was an alternative. Ondansetron was not, well, it was commercially available, but it was super expensive at the time. And there really wasn't a lot of alternatives. Now there are more. Ondansetron is generic and inexpensive. And I know I've heard people say, well, ondansetron doesn't work in 100% of cases. That may be true, but there are other products that are out there that can be used when ondansetron can't be used. And we have seen organizations who successfully done that without having the need to do promethazine. Unfortunately, we also are familiar with some hospitals that routinely use promethazine over other products on a routine basis. So they'll use more than 50% of their patients who need antiemetics are getting promethazine. And it shouldn't, we feel that at least the data that we've seen, there should be no clinical reason that happens. But organizations, now that there are other products out there, can do it. Yes, there are other safeguards you could try to put in place. I'm concerned about the IM one because you're sending a syringe to the floor. If the nurse accidentally gives it IV, you've caused the error as if you accidentally gave it intrathecally instead of IV vincristine. So again, the situations occur where the product, it's the same product and it's given the wrong route. That's an issue. If it's given as an IV or a mini bag, less chance of problems. But again, I think that there really should be no need for that in most organizations, and we've successfully seen others get away from it.
All right. No, good. And there's actually several questions along that same line that I think you have given the answers on. Why is this such a big topic? What are some of the other drugs that could be used with some of those other items that came up that I think you addressed with this has been a big issue with ISMP and previously, as Daryl already mentioned too. I mean, some of the alternatives were very expensive.
Right.
And that's no longer the case right now, so that this is something that we actually spent, and Daryl, as he mentioned too, I mean, this was a topic knocked around here, and even with our advisory panel, and feel that it is time that you could actually eliminate this product. There's a couple questions also regarding the new best practice 14, and one is, comment from obviously someone probably from California, talking about the California Department of Health in their medication error reduction plan requires hospitals to proactively identify weaknesses in med use processes, and also ties in nicely with the best practice 14 now from ISMP. And the other was asking a little bit more specific that would doing the quarterly review of ISMP's action agenda with P&T committee, would that suffice? Because you had mentioned monthly.
Right. I don't think. I think the suggestion was that if you meet monthly, well, first of all, if you don't meet monthly, it doesn't make sense. But yeah, I think it would meet the requirement. I think the requirement is the main goal. I mean, the sub bullets are there to give people an idea of what what they should do. So if you don't have a medication safety committee per se, it goes to a different committee. If you can't do it monthly, you do it quarterly. Yes, you can do that quarterly and meet the intent. The intent is to look at errors at other places and try to prevent them. Discuss your systems, review your systems, and discuss them within your own organization on a periodic basis.
There was also another one on, are there any resources other than ISMP that acts as a repository for general medication errors? And another one going on, again, along with that 14, with some of the best practices for learning from mistakes of others. And I think you did cover some of those in going over that. But any other comments on, I think you mentioned FDA and Joint Commission as some other good resources.
Yes, I think that one of the ones that people don't hear a lot about unless they're in Pennsylvania or Oregon is those organizations have their own patient safety authority, and they collect data on medication errors and put out summary data about those. And so that's a very good source. Also looking at what's happening to our neighbors up north in Canada also could be of value. The ISMP Canada puts out a newsletter, and they're funded by the government, so they get all the data. So they get a lot more information than I think we do through a voluntary process. But I do think that there are other sources that one could look at. I believe the Pennsylvania Patient Safety Authority information is freely accessible on the website. I believe Oregon is too. And there are other states that also have error reporting data that they can share. But even internally, you hear stories. You hear stories at your local associations. You hear people share information off the cuff, and even I heard recently about a case of a accidental vincristine administration in a hospital by somebody who got a call from somebody else asking, "What do you do?" And so it does. You do hear stories are available, and even sometimes in the newspaper.
Right, and I think as you mentioned too, in the state of Pennsylvania here, that with their reporting program too, there's the advisories that are available free of charge. That actually has some good information in there from the Pennsylvania reporting program, and anyone could, if you go to our website, in the bottom of the website, there's a direct link, and actually all the advisories are available and even searchable on there, which is another very good resource that ISMP actually is involved in that reporting program and analyzing some of that data and actually writing it up for the Pennsylvania advisory when it deals with medications. For best practice 9, do we have any list of those antidotes or reversal agents that we should prioritize first? since some of the barriers too have been it's taken so much time, or
I think actually in the best practice we do suggest some of them. There are some that, and I've talked to a number of organizations where people have said, well, we're not really concerned about benzodiazepine and flumazenil, and that's less important. Certainly one of the ones that we think is important, we've seen a number of errors, have to do with patients who undergo anaphylaxis and need epinephrine quickly, and there's no orders available. And by the time they get the order and administer the drug, it's too late. So I think that the problem with that one is not so much having the availability of the drug, although I know there have been drug shortage problems recently, but the other issue is making sure you have the protocols in place in the order so that you don't have to wait. But there are other ones for obviously, naloxone for opioids, having dextrose for insulin, reversal agents for anticoagulants. Those are some of the key ones. Some of the lesser ones you could work on, but I think are forgotten sometimes. Having, if you're using benzocaine spray, having the methylene blue available as an antidote, having there is a new drug out now that works for some of the neuromuscular blockers, but certainly lipid kits in the OR to handle problems with that. But we do list them, but there are a lot of them, and there's a lot of people who use products and other people who don't use those products, and so we specifically avoided coming up with a definitive list. At some point, I think what we're going to wind up doing maybe is surveying some organizations to see what they are including on their list and see if we could come up with a list of what people are using most commonly for that.
Okay. This is there was a question on the vincristine, and it may be a little too specific with here, but saying that they're using a closed system transfer device that they could lock out the ability to procure the interthecal adapter. And would that actually meet our best practice? I'm not sure if you have any comments on that. I know myself, I would. I'm not totally familiar with that you could lock out an interthecal adapter on that, but I would say that I think we've seen a lot of success with people just converting to the mini banks.
Right. And that's what the WHO recommends, and almost all the other organizations have said that, there's never been a death from vincristine administered by a mini bag. So I think you're taking a chance with anything else because you don't know what kind of workaround could be created to bypass the system. And unless you've actually worked on it or something, or until we have an error where that workaround has occurred, we probably won't know.
Right. There's a few more questions too that I'll just once again, any of the audience that's still on the lines, that if you are from pediatric hospitals, to let us know, because there's a few more questions, especially from pediatric hospitals, saying that that they're having a tougher time because of more limited number of drugs to use for nausea, vomiting in pediatric patients. So anyone on the line that may have been more successful for that, because a couple of these questions are asking, are we looking at any special considerations for pediatric hospitals? But at the current time, we're not looking at that at all. That's correct, right, Daryl?
Correct. I mean,
right.
We're asking people specifically to give us feedback, but until we get that feedback, we don't have anything specific on that for pediatrics.
Question here on best practice 8. asking about do they, to be in compliance, do they have to have infusion rate limits for chemotherapy in the pump library because they're struggling with this. And I'll let you take a stab at that first.
Well, we are having a ISMP is actually in the process of conducting a Smart Pump Summit where we're going to talk about, and we are in the process of revising our guidelines for smart pumps. My understanding is that you can successfully set them. The question is, how, I think what many people are trying to do is set reasonable limits. And where if you set catastrophic limits, doses that are way beyond, you may still be able to prevent certain kinds of serious harm to patients with the dose area reduction software. I believe I've talked to at least a couple people that have been able to successfully implement that for oncology. I do know it's harder, but and that's one of the reasons why outpatient infusion clinics were the last to use smart pumps. But I do think that I've talked to a number of hospitals that have successfully done it in their outpatient infusion centers with chemo, and it's worked. I think it's just trying not to be perfect again and just trying to make sure that you set it to a point where you can prevent the catastrophic errors.
Right. Yeah, and I would agree with that answer too, that that is one of those, that it may be one of those last places, like sometimes with anesthesia or the OR, that you could actually get full compliance with this, but it isn't something that you, it is something that you should try to achieve and strive for. Also, there's another comment here that the ARC Web M&M, if you're familiar with that, with a lot of our listeners here too, has some cases that could also be used for our best practice 14 on sharing errors. So that's something too that we could also keep in mind ourselves when we're looking at some of the FAQs or that may come up with some of these. Also, is there, again, with the lot on the promethazine that we've already answered some of those, or tried to answer some of those, and asking for us to put some pressure on the manufacturers, because as long as the drug's available, there's going to be an issue out there with using it. Also, some other comments too about with the IV work, that should be more pressure on hospital administration to take some accountability for that, because if it reaches that level, that if they were accountable for some of the errors, or that was actually, which they should be, as we say, shared accountability, there may be more uptake on that.
And Alan, I see one of the comments that someone gave, which I thought was interesting, is that they're actually glad about the promethazine best practice because they've been having a lot of issues with IM administration in their hospital, and nurses are not giving it correctly into the large muscle; they're giving it into the deltoid muscle, and so they're having a lot of issues with correct IM administration. So they're hoping that this best practice will help resolve that issue as well.
Yes, that was a good comment, and it actually was a good comment too, because there was a couple other questions before that asking about what about if you just use it IM? What's the big concern with that if you just have it available? And I think that's a good answer to some of those other comments that some listeners have already made about just having it available for the IM. Best practice 14, again, on finding errors outside the facility. I think we address that fairly well. And I'm looking for something here new. I guess one of the things while I'm looking through this too with Daryl is with some of the since you've been involved with these best practices since the beginning too, with some of the earlier best practices, have we seen some barriers that were identified actually go away because of time, like sometimes with technology or a new product or some things that have stood out with helping some of these move along?
One of the biggest ones I think has really helped is manufacturers of devices coming out with metric-only oral liquid devices. I mean, virtually every product on the market had not only mils and ounces, but grams and other forms of product like that. And now a number of manufacturers have taken to heart the best practice and created metric only. I think Neomed was one of the first with their oral syringes, and have improved upon their products. And I think other manufacturers have now taken to heart with that. I understand Baxter has as well. And now we're seeing the oral cups come out. And not only was the issue with the oral cups the fact that it had the 3 different scales on it, but also that they were hard to read. So we're seeing people address that as well. So I think there is increasing number of products out there now available for that best practice, which was a real problem to begin with. People were saying, well, we just can't find the right devices to use. And now they are becoming available. So, and we're seeing better implementation after these products became available.
Right. Now I think that's a great example of and again, we hope with some of these too that it would be even from some advances in technology, or even with manufacturers supplying some products or some dosage forms that would make it easier to implement some of these practices, and hopefully over the years too that we are looking for some of that. There's a couple questions on. It seems some people are having problems with downloading the handout and that, or printing it out. So that is something that we could follow up on.
Well, actually, we plan on posting the slides to the ISMP website in the targeted best practices area under education. And we'll also post a recording of the of this webinar as well. So we will have it available in the PDF format is in such that you can show it as a slideshow. You just can't edit it.
Right. Good. Thank you, Derek. Because I was just going to mention that too with the video or the audio being that will be available also. The same as we have with our high alert assessment too. That was something that promoting that audio is available on our website. Final question here looks like, and I think we may have had this with the Vin Christine, some of these comments with that. Some of the pushback is since they prepared in a 30 ml syringe, no one would ever administer that intrathecally. We have any comment on that, or versus?
We actually have heard stories of people, physicians actually trying to administer intrathecally as much as a 50 ml syringe, even though it doesn't make a lot of intuitive common sense to do that. People still will try. We've also had reports of people who have broken it down, take it out of the bigger syringe and put it into smaller syringes. We've seen that with a variety of products where people don't get it the way they want it, so they figure out a way to do it the way they want to do it. And so we've seen, I think, Alan, you're probably even familiar with situations where a nurse couldn't administer an oral syringe into an IV line because it wouldn't connect, so she drew it out with a parenteral syringe and still injected it. And I think that's the same thing with the vincristine. Just because you put it in a large-sized syringe, the potential for error is still there, and we have heard cases where it has been tried.
Right, and I think that is with some of these, as I open with too, and some of these are the low frequency, but very high harm events.
Right.
And that vincristine is one of those. So that is with some of the focus on these best practices too, is that we may not be reporting on them all the time, but they are preventable, and they are something that we don't. They're very high harm. It's almost fatal. I mean, it's fatal every time. So that these are the things that actually was some of the impetus for some of these best practices, whereas us getting frustrated on, why are we still getting reports on this after all these years? There's one comment here too that regarding the neuromuscular blocking agents in the anesthesia syringes with the 503Bs, trying to address some of the issue that how the syringes look the same as like neostigmine is almost identical to some of the other blocking agents, and are we doing anything about this? And we always, through our reporting program, these are the type of things that you could report to us. We're not always successful in getting changes made, but we do follow up with the manufacturers, and we do follow up with FDA on these type of topics. So once again, we may not hit a home run every time with these, but please feel free to report these to us. And even if you have the graphics with it to send along, because that is a way that we get a lot of changes made in the marketplace, is through your reporting on these. And I think we just about covered all the topics. I mean, there was a lot more questions, but a lot of them were on the same topics, or that you answered. Daryl, any closing comments?
No, I think that I just again want to emphasize that what we are striving here for is for people to work with these, to try and work at implementing these. Perfection is not necessarily always going to be achievable, but at least trying and trying to get as much done as you can within each of these particular best practices, I think will help move along. And that's why they're called best practices. These are the things that we feel are the best single one or two items that can really resolve the errors that occur with these systems.
All right. Thank you very much, Daryl, and thank all of everyone that participated in today's session, and also for your questions. And once again, with our upcoming programs with medication safety certification, Just Culture certification with a focus on med safety coming up, and also a medication safety intensive program coming up, that are on our homepage on our website, that you could get some further information, along with further information on the best practices. And we will be downloading these slides. So with that, I hope all of you enjoy the rest of your day. Thank you.